Left ventricular diastolic function as seen by spectral tissue Doppler. Now, how to evaluate the diastolic function of the left ventricle using spectral tissue Doppler at the region of the mitral annulus. It can be studied in this region of the myocardium at the IVS close to the mitral annulus in an apical fourth chamber, or in this region of the myocardium at the lateral wall close to the mitral annulus. As you know, the spectral tissue Doppler is the same kind of Doppler used for blood flow studies, except that it has a filter that only shows the low velocities of the walls and not the high velocities of blood flow. Another filter only shows the strong Doppler echoes coming from walls but not the weak echoes coming from blood flow. In other words, it demonstrates very well the velocity and direction of the movement of the left ventricular walls, but not the blood flow. What we study as a spectral tissue Doppler is the velocity of this region toward and away the left ventricle apex, or better yet, toward or away the transducer at the apex. During systole, the basal region of the left ventricle is pulled by the ventricular contraction to the apical direction. Then we see a positive velocity in the tracing going up at the transducer direction, the S' wave. It reaches a maximal velocity and then it decreases its velocity until it stops and begins to return during diastole. This diastolic return brings the annulus back to where it was before in two negative waves, the E' during the initial relaxation of the left ventricle and the A' during atrial contraction. It usually is more often analyzed in this region of the lateral wall than at the IVS, but the velocities are different if analyzed here at the lateral wall or there at the IVS. That's one of the problems with it. It should represent the global diastolic function of all the left ventricular, but it doesn't. It suffers a lot of local influence, like the local longitudinal contraction and relaxation of the lateral wall or the septal walls, as well as the local circumferential and radial contraction and relaxation of the left ventricle. I prefer the lateral wall because of the intense influence of the aortic movement in the IVS velocities, not only during systole, but also during diastole. Basically, we're going to analyze the amplitude of the E' and A' waves in consideration to diastolic function. Obviously, the more ventricular diastolic filling, the more velocity of this region, returning from the initial systolic pull toward the apex. In normal conditions, the E' should be greater than 10 cm per second at the lateral wall and 8 cm per second at the IVS, and it should be greater than A'. The A' amplitude is not usually measured. Its main usage is for comparison with the E' wave. We can also analyze the isovolumetric contraction period that usually produces two minor waves just after the A wave return to the basal line and before the S' wave. One positive and then a negative. The positive wave may have a high amplitude enough to be mistaken to the S' wave. The isovolumetric relaxation period also happens in two minor waves, one negative and then a positive, just after the S' wave return and before the E' wave. Now, an abnormal tissue Doppler at the lateral wall. The E' wave is less than 8 cm per second and lower than the A'. This demonstrates that the region which was pulled apically during systole now returns slowly in the initial third of diastole due to poor left ventricular relaxation. What we're doing here is to use the tissue Doppler mainly to differentiate the normal mitral flow from the pseudonormal, since both have the same aspect, as we have seen already in past lecture. The E' velocity, in case of pseudonormal, will be diminished and smaller than the A' wave. It will also be diminished in type 3 and 4 restricted patients. Another use of the tissue Doppler is to evaluation of capillary wedge pressures. This is performed using the relation of the E wave velocity of the mitral flow by the E' velocity of the tissue Doppler. This relation, when greater than 15, indicates a pulmonary capillary wedge pressure abnormally high, and if less than 8, this pressure would be normal. This E' relation has been shown not to be useful in patients with normal hearts, and more recently also in patients with heart failure. Studies from the Cleveland Clinic showed almost no correlation in patients in ICU, and when the pulmonary capillary wedge pressure was altered medically, the change in E/E' did not correlate with the direction of change. In my opinion, we cannot trust the accuracy of this spectral tissue Doppler to analyze the pulmonary capillary wedge pressure. One of the main problems with evaluation with spectral tissue Doppler is the variation with the position of the ROI, if in the IVS or in the lateral wall. Notice that in the same patient, if the ROI is at the lateral wall, the E' is greater than the A' and measures 12 centimeters per second, absolutely normal. Now, with the ROI in the IVS, the E' is lower than the A' and measures 7 centimeters per second, then abnormal. This difference should not exist since we are analyzing the diastolic function of the left ventricle as a whole and not a regional function. Another problem with tissue Doppler is that, as any Doppler, its measurements are dependent of the incident angle in relation to the evaluated movement. And what we analyze with it is not the real amplitude of displacement and return of these sites, but their velocities. And this velocity is a vector and depends of different velocities, like the longitudinal displacement in apical direction, that we think we are analyzing only this one, but also there is a circumferential or rotatory velocity and the radial velocity toward the center of the cavity. Hence, the resulting vector of these three velocities is the velocity we are recording. It may have an important radial velocity that may not be seen if the incidence is perpendicular to it. The same velocity may now be well seen if the transducer is repositioned slightly to a position where the incidence favors the demonstration of the radial velocity, but we will wrongfully take it as the longitudinal velocity.